thank you very much for joining us on 11th May for the next edition of the virtual expert board. As usual, we have the usual suspects as moderators, Dr. Sahoo, Dr. Amish Vora, and Dr. Ullas Patra. Next, please. And this time we have a galaxy of esteemed faculty as panelists who will give their expert opinions. We are awaiting joining by Dr. G.C. Khilnani, who is ex-head of Department of Pulmonology from AIMS, New Delhi, and is now director of PSRI. We also have for the first time Sheila. She is a dear friend and in charge of a lot of things at not only at Tata Memorial Hospital in the intensive care unit and the anesthesia departments, but she also represents India in several international bodies, and they have recently come out with several recommendations as well. And I will ask Sheila to explain all of that. We have three people from UK. That's a great privilege. Nandita has been there with us, and now we have two more, Eric and Beata. Beata. Eric is especially important for us because he is the principal investigator of the REMAP CAP study, and I think part of that is going to be an important discussion today. We have Neil Nabar, who's an internal medicine specialist from Bethesda NIH, and we are having him here for the first time, and we hope that he will find time to join us in the future as well. We have Akhil Kapoor, who is a medical oncologist in charge at the large COVID center in Varanasi. And I think that he keeps treating patients till 1 a.m. in the morning. So he might be a little delayed in joining us. We also had Dr. N.N. Prem, who was going to join us, who is a geriatrician. Unfortunately, his relative has just been admitted with COVID. So he has sent his regrets that he will not be able to join us. With these introductory comments, I hand over, next slide, to Dr. Amish Vora to moderate the first part of today's discussion. Over to you, Amish.
Thank you so much, sir, and really thankful to you, sir, for getting together so many experts on the.
Can I just interrupt you? Dr. G.C. Khilnani has just joined. So welcome, sir. We just introduced you. You were ex-head of department at All India Institute of Medical Sciences. And now, sir, you are director of PSRI. Once more, RTS, welcome to you. Amish, please continue.
Thank you, sir. First of all, thank you, Parikh sir, for getting so many experts on a common platform. I think this is extremely important and we are always thankful to you. So I will start. The topic of discussion today is between OPD and admission. So let's start that 65-year-old male, CA rectum, is on FOLFOX chemotherapy. All non-oncologists, FOLFOX chemotherapy is chemotherapy every 14 days for 6 months approximately. So the patient was on chemotherapy. After the last chemotherapy, day 13, TLC is absolutely okay. Tomorrow, patient's chemotherapy is due and a routine RT-PCR before the next chemotherapy comes out to be positive. Patient contacts, as everyone in Delhi contacts, they are contacting either their GP or a physician or a COVID expert, and patient is already started on doxycycline, ivermectin, zinc, and vitamin C. There is no comorbidities with patient. Patient is absolutely fine till 5 days. On 6th day, patient starts developing cough, some dyspnea on exertion, and 6 minutes walk test, the saturation drops to 91% from 95%. Patient goes for CT scan and the CT scan CORAD score is 16 on 25. So this is the background for our patient today. Can I have the next slide, please? Yes. So Dr. Khilnani, sir, welcome. And the first question to you is, what would you advise this patient the next steps?
Please unmute yourself, sir.
So thank you very much, Dr. Amish and Dr. Parikh, good to get in touch with you after a long time. And I thought this question would come to me only because managing COVID, and I may not know the intricacies of malignancies, but this is so a person who has got 65 years of age has got CA rectum as a malignancy. It's not unusual to have a score of 16 by 25, 15 by 25, with a mild cover, even without cough. What is important in COVID care is, and especially in the second wave we are seeing, is that unpredictable downhill course in these patients. So therefore, from the fourth or fifth day onwards, we start evaluating them based on their comorbidities, starting from age to diabetes to hypertension to CAD to COPD, and of course the malignancy and rheumatic disease and so on and so forth. And fifth day, we start, our tentacles are up. We want to do CRP, we want to do D-dimer, we want to do CBC, look for lymphocyte, we want to do ferritin and IL-6. And at the slightest indication, we do a CT scan. Now, although all the guidelines says you wait for the saturation to drop less than 94 and then you wake up, to my mind, by the time the saturation drops, it's too late for any patient, So to pick up earlier, there are two things. One, that you do a CT scan, and to my mind, more important is to do inflammatory markers, out of which CRP is most important, D-dimer is second, ferritin is third, and lymphocyte count and IL-6, in my experience, is the most unpredictable and unreliable feature of severity of inflammation. All these things will help me in deciding a future course of action, how aggressive I should be in admitting them, how aggressive I would be in treating them, whether to treat them with remdesivir, to treat them with steroids, when to give anticoagulation. I guess all those things we'll be discussing later. So I'll stop my comments here, and then if there are any questions, I'll take up.
So Dr. Neil, what Dr. Khilnani sir said, and Kashish, can we have the previous slide, please? So this slide says that 6 minutes walk test, the saturation dropped to 91%. The C-reactive protein at this point of time is 56. D-dimer is 332. Ferritin is 650. We can go to the next slide. So based on what Dr. Khilnani said, what would you do this patient in your practice, Dr. Neil?
Yeah, so here in this patient, I'm starting to get very concerned. It seems like we have some elevated inflammatory markers from what you're saying. We have a patient whose 6-minute walk test is below 92, which means in the outpatient setting here in the United States, I'm sending that patient to the emergency department for an evaluation. Just kind of based on a 6-minute walk test really being below 92. That's what we've been using as a threshold here to make sure our outpatients get evaluated properly in the ED. And I would expect the emergency medicine doctor then to begin running kind of the admissions test that Dr. Khilnani just kind of suggested. So starting to get the CBC, the CMP, we want the D-dimer, CRP, ProCal. And it looks like we're at day 6, right? Between day 6 and 8 after symptoms, these patients really begin to teeter. And we're worried that, they really could fall off a shelf very quickly. And so this patient likely needs continued observation, and looks like they're heading towards requiring remdesivir. And with the elevated inflammatory markers, really we're thinking, long-term, it looks like this patient might even need escalation of care to immunomodulatory therapy.
So Dr. Neil, the point is that you will advise admission for this patient, and Khilnani sir, I would assume that you would also advise admission for this patient.
Amish, there's no question about this patient getting admitted. Absolutely no question. And I didn't go ahead with the treatment. I guess the first question was, what will you do?
We will go towards the treatment.
Yeah. So if this is the patient who requires aggressive treatment at this stage, and antivirals are the first one, which should be given.
Correct. Absolutely. We will come to that, sir. So both the experts believe that this patient, there is no doubt, would require admission. Can we have the next slide, please? So AIMS with ICMR 7 days back have come out with this model of mild, moderate, and severe. And in moderate disease, if you see, if the slide is visible, the respiratory rate more than 24 per minute with breathlessness and saturation of less than 93% in the room air. This is what they have not defined any imaging criteria to define moderate disease. Can we have the next slide, please? So Dr. Makowski and then followed by Dr. Sheila, the CDC guidelines just 1 week back, I took out from that the moderate illness is defined as individuals who show evidence of lower respiratory disease, either during clinical assessment or imaging, and who have oxygen saturation more than or equal to 94% in room air. So Dr. Makowski, between CDC and Indian guidelines, there is a discrepancy. How do you define moderate disease? I would like to know your opinion. Where would you put moderate patient as? Dr. Makowski first and then Dr. Sheila for her comments.
I believe this is moderate COVID and requires some urgent treatment at that stage. And I believe, well, I would suggest if the patient requires oxygen, so it would be indicated to give him some dexamethasone according to the guidelines. Remdesivir is a very difficult discussion. Yeah, we don't use the remdesivir for the severe COVID, but I think the mild and moderate probably would be indicated. The evidence says that in the severe COVID it doesn't work and worsens the outcome. So I wouldn't try that. And obviously the investigations which were mentioned before, like a PCT, all these inflammatory kind of markers should be taken. And this is my kind of feeling.
Right. So Dr. Makowski and every panelist, I would again reiterate that this panel for next 20 minutes or so, what we are trying to discuss is patient is in the OPD, patient is still not admitted as yet, patient has not got the admission bed. In between this transition, what are we going to do? That is the main idea of discussing about this patient. Dr. Sheila, patient is not yet admitted and you saw the profile of patient.
Yeah.
Could you put this, assuming that 6 minutes walk test is not there and the room air saturation is 94%, where would you put this patient as with the inflammatory marker report which I showed you?
Yeah, so this is very important, Amish, the question that you asked me. To be very honest, I wouldn't go by the inflammatory markers. I would go more clinically and see how this patient is. If this patient is 94 and you can easily make him do a 6-minute walk test because he already has a pulse oximeter. And if you see a drop more than 4%, like you said, it came down to 91 or whatever, I would be very worried about this patient. There is no doubt that this patient needs to be in a monitored area, because this patient can decompensate and rapidly deteriorate and should not be at home. So definitely I agree with all the panelists. Regarding mild, moderate, severe and critical, this is very well defined by the WHO. So it's there on the WHO guidelines. At the moment he would be moderate, but I would say he's proceeding towards severe, because once he becomes oxygen dependent, he's going to fall in the category of severe. So I would say he needs hospitalization and he needs to be in a monitored area, and he needs further assessment for any deterioration in respiratory function. And very often what we see in the intensive care unit is we see very bad CT scores, scans, very high CT scores, but the patient is clinically absolutely fine. So we wouldn't go only by imaging and we wouldn't go only by the inflammatory markers. In COVID, one of the things that we have really learned is that you have to look at the clinical profile of the patient before your...
Dr. Sheila, would malignancy of CA rectum on chemotherapy play on your part when you are assessing this patient? Because that is what we are for, COVID in cancer.
Right. So as you know, I work at the Tata Memorial Hospital. So every patient I deal with is a cancer patient who's coming to the intensive care unit. So if the oncologist feels that this is a patient who deserves an intensive care admission, definitely, just because this patient has COVID, this is not a reason to not be aggressive with this patient. So definitely we would go ahead and give it the best, because this is something that is treatable. So,
great. Can we have next slide, please? Okay. We have covered this. Dr. Nandita, do you have something to add assuming this patient's inflammatory markers are not very high and saturation at room air is 94-95%, patient says when I lie down in the prone position, my saturation comes up to 96-97%. Would you be worried about this patient? Dr. Nandita and then Dr. Bieta.
Thanks, Amish. I would be worried about this patient considering the other history and recent chemotherapy.
Okay.
Can you hear me? Can you hear me?
Yes, we can hear
you.
Yeah,
sorry. Yeah, so I would be worried about this patient. And I would also, like Dr. Maitra said, that you would want to get this patient admitted. In our hospital, it will be under the surgeons or this. So we possibly at this stage may not be involved as much, but yes, this patient has got the tendency to go off very quickly. So we would keep a very close eye and possibly start him on oxygen as well. So in that case, as Dr. Makowski said, it is slightly different in UK when they'll be coming into say the A&E, and the A&E starts the process. So that's how it goes, and therefore he will then get admitted.
Thank you, Dr. Nandita. Dr. Bieta, I assume my pronunciation is right. Apologies if it is wrong.
It's very right. Thank you for
Bieta, forget about what the patient, 65-year-old patient, CA rectum on chemotherapy. Room air saturation is 94%. In lab, on the prone position, goes to 96-97%. Just 1 day history of cough and breathlessness. Would you be worried in this patient?
Yes, I would worry about this patient because having previous chemotherapies, he is immunocompromised, and this is my main worry. So he needs monitored bed. I would start him on dexamethasone, and I encourage him to be self-prone because this works well, and I'm sure that this patient himself, he noticed improvement. So we always ask these patients to do as long as possible, and if they are not extremely obese, they do really, really well. But he needs to be closely monitored.
He needs to be closely monitored. Next slide, please. Okay, Dr. Akhil, you are in the thick of COVID management. Dr. Akhil, Dr. Sheila is in charge of admission, and she says that, Dr. Akhil, 48 hours, I cannot give you bed. You manage this patient. How would you manage?
Sir, I would definitely like to start dexamethasone, whether IV or oral, whatever is feasible. And also, I will be very keen to start Clexane to this patient as well.
Next slide, please. Yeah, Dr. Akhil, go on.
Yeah, so both dexamethasone, either oral or IV, whatever is feasible, both appear to be equally effective to me, and subcutaneous enoxaparin. I will start these two things at least on the home care basis, and also will, as others have pointed out, strict monitoring and follow-up.
Dr. Makowski, between apixaben and low molecular weight heparin, what would you start, and would you start every cancer patients on anticoagulants?
So we work on ICU and in critical care. So we tend to use just basically dalteparin rather than apixaban. Why? Because we do a lot of interventions. It's easier for us to stop and do some interventions because they last shorter. And we, according to the RIMAP-CAP, we previously, before the evidence from RIMAP-CAP, we used to rely on the D-dimers. So if the D-dimers were certainly more than 500 or 1,000, we used to give a lot of dalteparin. Basically, we used to use therapeutic dose, but according to the RIMAP-CAP evidence now, is not beneficial for the patients. So what we're trying to do in our hospital, and we probably in the UK, we use just 5,000 for below 500 of the D-dimers. And if the D-dimers are higher, or patient is obese, we use this dose BD. This is what we use.
Okay, I will not go on steroids because that is a separate panel discussion what we are going to have. Non-rebreathing mask. I would like to ask Dr. Neil and then followed by Dr. Sheila. Non-rebreathing mask, we keep reading about it, but in practice, in reality, before patient gets admitted, how practical it is to use non-rebreathing mask? Dr. Neil followed by Dr. Sheila.
So I got to tell you, it's not something that I've done over here with any frequency, and so I can't really comment with a whole lot of expertise on whether it works or not, because it's just not something that we recommend, that I've recommended over here with any frequency. So
okay, because this is one of the recommendation of ICMR with AIMS guidelines. Dr. Sheila and Dr. Khilnani, very quickly, patient is on oxygen concentrator, saturation is 96%. Patient is on low molecular weight heparin and steroids. Would you like this patient to get admitted? Dr. Sheila followed by Dr. Khilnani.
Right. So if this patient is oxygen dependent, definitely, again, it depends when you say hospital or not in hospital, it is a monitored area. So if you're able to provide oxygen in a monitored area with someone with the expertise to identify, a patient who's deteriorating and monitor him, then it doesn't matter where it is. For example, at Tata Memorial Hospital, we're even using high flow nasal cannula oxygen therapy in the wards. So if you have the expertise to manage it, it doesn't mean that this patient has to come to ICU. Coming to the non-rebreather mask, yes, we are using this. And then we, depending upon the level of monitoring, we set the oxygen target. So it doesn't have to be that every patient has to be at 94. If we know that a patient is, maintaining at 92 and we can quickly transfer him to the ICU if he deteriorates, we're okay even with a saturation between 90 to 92. And we would, if he requires more than 10 liters of oxygen, then we would, and he's tachypneic on this, then we would consider further escalating support.
Understood.
So
Dr. Khilnani, sir. Understood. Thank you.
Sorry,
sir. Sorry, sir. Before you answer, I would like to rephrase my question. Patient is searching for bed. Patient is not getting bed. This patient on oxygen concentrator maintaining saturation as 96%. Patient is on oral Medrol. Patient is on low molecular weight heparin. And patient is in the proning position also, awake proning. Does this patient is in emergency requires admission?
In my mind, yes, because in our experience, this, especially in the second outbreak that we are seeing in India, a lot of patients are crashing within 24 hours. A lot of young patients, immunocompetent as well as immunocompromised. And we know that oxygen concentrators have limited flow. Majority of them have, 5 liters, maybe now we have 10 liters, but you cannot give FiO2 of more than 0.4%, 0.4 by these. So therefore, we have faced all this situation in Delhi in last 3 weeks time when we had to manage very sick patients at home because there were no beds. But what we should aim for is ideal. So therefore, this patient is absolutely unfit to be kept in the home setting, even if there's a staff nurse who is very well trained and you are able to give medication. Medications don't save the patient. Medications don't prevent death majority of time. The most sickest of the patient are salvaged because of the good intensive care, good oxygenation, for which the oxygen concentrator is not good enough. However, if you want to give high flow oxygen, the cylinders are preferred to oxygen concentrators because with cylinder you can give high flow oxygen with Venturi mask or even with partial or fully non-breathing mask. So my answer is very straight and simple that it's not a choice. When you don't have a choice, then you keep patient at home. Otherwise, every such patient should be in the hospital setting. I'll go a step ahead, that in a hospital which has an ICU setting, then this patient can be kept in the ward so that anytime, if required, he can be shifted to the ICU. Thank you.
Got it, sir. Next slide. Okay, the last few 2 slides from my side. Khilnani sir, since you are there, if this patient has not received favipiravir day 6 today, and patient is not getting bed, just a simple yes or no, would you give favipiravir to this patient?
To my mind, this is my personal opinion that The evidence of benefit with favipiravir is very sketchy. And I would be very candid that I do not start favipiravir in patient with the hope that it will prevent mild disease from turning severe disease. One, but if somebody has prescribed it, I don't stop it. And that's my opinion, so I won't go beyond that.
Dr. Akhil, what is your thought process about Virafin? And maybe Dr. Neil can talk about favipiravir after you. Dr. Akhil, you have seen that interferon alpha 2b has been approved by DCGI as a single dose. Would you give Virafin to this patient?
Sir, personally, we have not used it till now. But if there are some positive experience from other colleagues, I would be using it. But presently, I have not used it.
Presently, Dr. Neil, what is your take on favipiravir? I know in the US, I don't think you people use it.
We don't use.
You don't use it. Okay, right. So we heard Dr. Sheila is working in ICU and Dr. Hachos is also working in ICU. So I would move forward. Dr. Sheila, or if the patient is not getting beds, if there is an outpatient department somewhere, would you be comfortable giving remdesivir in that outpatient? And maybe we can ask Dr. Bieta also on the same. Will you give remdesivir on outpatient basis?
So here again, it's not about just outpatient basis. I would first discuss in which patient do we give remdesivir, because I see remdesivir is just being given.
This particular patient is in front of you.
So
you give or not?
Yes. So if firstly the evidence is very weak for remdesivir at the moment, and I would give it in a patient who's oxygen dependent. Definitely this patient fits in that category, and someone who's not yet on mechanical ventilation, because that's where we have the highest evidence.
So this patient is not on mechanical
So we would consider, and definitely antivirals should be started early. Regarding any of the other medications, as Dr. Khilnani has rightly said, it is not these drugs that treat the patient, but very good supportive care. So I wouldn't give any of these medications.
Dr. Bieta, would you give remdesivir on an outpatient basis in this patient? Patient is oxygen dependent, not on mechanical ventilator, and day 6 is not very late. Would you, if the beds are not available?
Yeah, I would give it because, in my opinion, it can prevent this moderate disease to progress to severe, but only in these circumstances. But
only in these circumstances. So we all agree that remdesivir can be given, antiviral can be given in this patient because within first 7 days of symptoms, not on mechanical ventilator. Parikh sir, not asked you any question, but if the GCSF, if the TLC count is low, assuming this patient, would you give GCSF in this patient because the cytokine storm has already started, the inflammatory markers are high, and CT scan score is 16 on 25?
All right. Thanks for the question, Amish. Instead of GCSF, I would like to share something about GM-CSF that I read recently. From the University of Ghent in Belgium, there is a data on a randomized study in 81 patients with desaturated oxygen due to COVID-19. And this GM-CSF was given by nebulization. So it was given by inhalation in patients who are not yet on ventilators. It was given twice a day for 5 days, and it showed a dramatic improvement of more than 33% improvement in oxygen saturation in half the patients. Based on this study, there is a new study started in the US that will enroll 125 patients. And the hypothesis is that the M component of GM-CSF stimulates the macrophages in the alveoli of the lungs, and that actually reduces the inflammation and causes improvement. So I'm very intrigued by this data, and I would use GM-CSF rather than GCSF.
Excellent, sir. No, I was not aware of this data. Thank you so much. Khilnani, sir, the last slide. Khilnani, sir, your comment also. Next slide, please.
Can I have give a comment, please?
Yes, sir.
This is about remdesivir, and this is the most controversial topic, and I must clarify and put forth my thought process. The initial recommendation based on the Gellert study was that if the oxygen saturation less than 94%, patient on mechanical ventilation, ECMO, and all those things should have the benefit of remdesivir. But subsequently, another randomized trial in JAMA clearly showed that patients with pneumonia who did not have low saturation, there was significant improvement in the clinical condition based on the ordinance scale of 11. And also the mortality benefit was 7 versus 11, which was not significant. Therefore, my thought process is, if there is a patient who is immunocompromised, if the patient has significant pneumonia, the oxygen has yet not gone down, this is the candidate who would respond to remdesivir. The reason is that remdesivir is not effective once the patient goes on mechanical ventilation or if the 7 days have passed by. The viremia is there in the beginning of the illness. So if you wait for the deoxygenation to occur, you are actually waiting for too long. So I use remdesivir early and I follow that JAMA article. Thank you.
Thank you, sir. Sir, since you are there, my last question to all the panelists, and just a simple yes and no, because we have one more panel to go forward. Based on the recent media highlights and the article, which is almost like a peer-reviewed meta-analysis type of thing, and Goa government has mandated everyone to use ivermectin. Immediate global ivermectin use can end pandemic. This was Indian Express headlines. Khilnani sir, to start with you, would you use ivermectin in treatment and prophylaxis both, yes or no, sir?
So I would quote a study which was published in JAMA, a randomized controlled trial involving large number of patients, where they tried ivermectin for preventing mild disease from turning into moderate disease, and there was absolutely no benefit. Based on that, this is the only randomized trial which has shown that ivermectin does not work. So I don't agree with the recommendation of the Goa government.
So sir will not use. Dr. Makowski, 1 minute, Sheila, I'm coming to you. Dr. Makowski, have you ever used ivermectin, or do you follow this peer-reviewed research?
I don't think it's available in the UK.
Okay.
There's no experience at all from my colleagues. I don't have personal experience as well.
No personal experience, no experience from colleague. Dr.
No
Sheila.
So just coming to this meta-analysis that you're talking about, this has created so much of media hype, both for prophylaxis and for treatment. Definitely, I would say one should not use ivermectin. If you look at that meta-analysis very closely, it has got unpublished data, website reports, very small, underpowered study. It's very unfortunate that Paul Marek and Meduri are part of this, meta-analysis. And I would really not go by this, because this has created so much of hype. And I agree with Dr. Khilnani about what we need is a large randomized controlled trial, if at all. And it's very unfortunate that, just based on this meta-analysis, people are advocating using it both for prophylaxis and treatment. I don't think we should use.
So, no, 4 panelists have. Dr. Bieta, I also hear that you don't have any personal experience. I would take it as no from you.
No from me as well.
No from you as well. Dr. Akhil, yes or no?
No for prophylaxis. We are using it for therapy purpose.
For therapy. Dr. Neil, any experience of ivermectin? It is one of the largest claim. Yes.
No for prophylaxis, no for treatment. I would point to the same trial that Dr. Khilnani suggested earlier in JAMA. There was no benefit in the only significant randomized trial that looked at it. I don't think there's any data to suggest ivermectin use at all.
And
right. So,
Sheila, one point, BMJ has just come out with a very nice editorial, and I urge everyone to read it. It's just come now. And they've written about this meta-analysis and the 22 randomized controlled trial and the small study and the low quality of evidence that exists. I think it's a very well-written editorial that's just come out, clearly stating that ivermectin should not be, used for this purpose.
Right. So with that, I will close my discussion here. But Tarini has clearly said, and I would ask Tarini to take it forward. My personal experience has been that ivermectin in AIIMS, in PGI Chandigarh, in Bangladesh, in Assam, in healthcare workers, it have been used, it have been published. There is no harm in using that. and everyone I know of in India, especially in Delhi, have been put on ivermectin. I think we have still more data from India before we can just blindly follow JAMAs of the world and say that yes, it is useful or not useful. With that, I'll close my panel. Over to Dr. Tarini, please. We have
Thank
the
you,
same
Amish.
panel, so you all stay back. Huh?
Yeah. Just before I go in, I think there's a chat that is about methylene blue. Before I go into the panel, just to clarify, Dr. Sheila, can you come in on that? What is your thing? What do you think? There's a lot of hype in India about the methylene blue thing.
I would not use this at all. We don't have robust evidence. There is this feeling that because something is cheap and because the side effects are not high, you can just give anything and everything to the patient. There's a whole a list of drugs that the patient is already on even before coming to a hospital. And I think this has to stop. People are just going on and on thinking, and I think Dr. Khilnani hit the nail on the head by saying it is not these medications, but good supportive care, timely use of steroids and anticoagulants that saves your patient. Everything else is plus minus, and there is no robust data to use methylene blue in these patients.
So I hope that the question is answered, which was in the chat for 2 times. So now we go to the next slide, please. So I'll be very much restricting myself to these 2 things. Okay. So can I come down to like Dr. Nandita? For me, there has been a lot of confusion. What is a cytokine storm? So is it a clinical thing for you? From the whatever discussion happened, the more of what I got from all of you is it's more clinical than anything biochemical. So is it a clinical or is it a combination? So can we answer that first?
Yeah, I think it's mostly clinical, which say, and we don't measure IL-6 levels in our hospital. So yes, we are doing blood tests every alternate day or every day for intensive care ventilated patients, but it's mainly I feel mostly clinical, for backup from blood tests as well.
Okay, Dr. Beata, if I can bring you in, we have a patient who is on day 9 of a COVID infection in the ICU, and there is a worsening of the chest X-rays, and would you still, before you term it as a cytokine storm, would you do a procalcitonin, and if it is normal, then you would call it a cytokine storm, or would you just wait for that procalcitonin report?
We normally on our ICU, we do PCT procalcitonin on alternate days, and we are guided by that on a superimposed infection.
That is true. But if the patient is deteriorated, to differentiate between a storm and a infection, would you wait for that procalcitonin, or would you just define it by clinical?
No,
okay, you would not.
Guided by my clinical assessment. Yeah.
Dr. Ullas, to bring you in, one of the highest you have seen with the cancer patient. For you, what do you define? Is it for you IL-6, the hype that has been around IL-6, or is it just a C-reactive protein, or for you also it's clinical?
Clinical.
Okay.
I don't
so
think IL-6. I think IL-6 and CRP are widely overhyped. Is the clinical situation?
Okay, so it's a clinical. Coming down to Dr. Neil, the last publication from the tocilizumab has come into to take a criteria of the C-reactive protein mode beyond 75. So because the entry criteria itself mandated the C-reactive protein to be there beyond 75. So is it that we can just do a C-reactive protein? Why I'm asking you that is a much easier test to be done, much cheaper, and hospitals, most of it, even small hospitals in India, do it in-house. So is it just I do a C-reactive, I get it in an hour, I do the clinical findings, the patient is worsened, X-ray is bad, I term it as cytokine and I go ahead?
Yeah, so I mean, I think obviously it's a much broader picture than that. You need to certainly take into consideration. I mean, I would be looking not only at CRP but also at ferritin. We don't really use IL-6 in the hospital very much. It takes forever to come back, and we haven't found a whole lot of use with it. So we're gonna kind of take the broader clinical picture. Though in our hospital we do have a pretty hard cutoff. You do need a positive CRP in order to start TOSI. But
so what's the level? If you can come in,
CRP alone will not doesn't really make a patient eligible for TOSI treatment.
So what is your level in your hospital as a policy? Which levels of CRP would you term?
They use 7.5. Same. It's the same as the study. So that is the level that's used, but it's kind of in the broader clinical picture of a patient with worsening status. So either 4 liter, they've gone up on their oxygen requirement in the last 24 hours.
So basically, that's what we're getting. To coming to my Indian panelist, Dr. Khilnani, sir, you are a very senior one. So if for you it's the same thing or anything extra you want to add it?
No, nothing. I just want to say, out of all the inflammatory markers, in my experience, CRP has been, which was actually dumped inflammatory marker. In COVID times, the CRP has been the most accurate marker which correlates with the severity and the response to therapy. But I'm not able to give you a cutoff. If the person is deoxygenating and the CRP is high, we treated
That's
as
right. Okay. Dr. Sheila, the time frame of occurrence. Usually it's the second week. Yeah, please. Yeah.
I'd just like to add that I would go more clinically, but definitely I would do the inflammatory markers. And as Dr. Khilnani said, CRP definitely is something I would rely on. And as far as tocilizumab goes, it works best in patients who are already on steroids and have elevated CRP and when used early. So if I see clinical deterioration more rapidly, and I have to choose between patients, I would go in for that patients rather than, make my decision based on CRP alone.
What is the time frame do you find it? Because sometimes we hear that on day 2, day 3, there is the deterioration. Is it that the patients were just asymptomatic or mildly symptomatic at home? Because this storm usually happens beyond day 7, or do you find that the things are changing?
Much earlier, I would use it in critical and severe and critical COVID only, and not on patients who are ventilator dependent, and as early as possible when you see the deterioration.
Dr. Makowski, you have been one of the investigators in the RIMAP CAP, and with putting these trials into perspective, if this is there and you have a cytokine storm, which would be your treatment of choice, or would it be a combination? What would you do?
So in the RIMAP CAP, we had obviously it was a trial done on the patients in critical care. So, and the protocol says you would give the tocilizumab within 48 hours. Most of the patients at that time, when we introduced the tocilizumab, they were already on dexamethasone because it was a finding from the recovery trial. So as early as possible, this is my view, once the patient is in critical care. And I've seen quite a few miracles after tocilizumab, and I had some disappointments as well. But I think this is kind of, we give in our hospital is in the protocol. So and initially in the RIMAP CAP, there was nothing mentioned about checking CRP or any inflammatory markers or even PCT. Some of my colleagues, they just transform this protocol now. And some of the patients, before giving tocilizumab, they do procalcitonin just to make sure that it's a cytokine storm. And basically, in our hospital, the PCT is available within 5-6 hours. So, and some people wait. I don't wait. If I feel, I rely on my clinical judgment.
So I was coming to the same question, that if there is a very high procalcitonin on a deteriorating patient, would you not give tocilizumab because it can accentuate the bacterial infection? That's what the question I put to Dr. Bieta.
In this situation, I wouldn't give tocilizumab. I just wait out. Yeah.
Okay. So Dr. Sheila, as I get it now, is that you also believe that in a deteriorating patient where secondary infection could be a possibility, we should be doing procalcitonin, especially before giving tocilizumab?
Yeah, procalcitonin I would do, but again, procalcitonin can be elevated in other conditions. But yes, this will give you a fair idea, and I would be, if I had to select, then I would avoid giving it in such a patient.
Okay. Okay. So if you have a doubt in that, would you just err towards giving bevacizumab, although the data is very sparse?
I just want to tell you something about bevacizumab. So people, there is a problem with the shortage of tocilizumab, and people are thinking that bevacizumab is a replacement for this. So this is not an IL-6 inhibitor. It acts on VEGF. And I find this very strange that people think this is equivalent to tocilizumab. And the data is so weak, and people are using this. And being in a cancer center, the two patients I've seen in non-COVID who've come to ICU, colonic cancer came with perforations. So this is not a drug without complications. I mean, I'm not an oncologist, but I'm just saying that I've seen really bad complications with bevacizumab. So I'm a little worried about people in the community advocating the use because tocilizumab is not available.
So now I have a cytokine storm. The reality of the day is I don't get tocilizumab. The patient goes around the city, doesn't get one. You need to give something. There are at least 2 publications for bevacizumab, to be fair to it, although small. One to a communication to the Nature and one from Bangladesh Army Hospital. With all of that, the idea that all of us are getting is that it might work. The reports, all those past, low quality, that has been very interesting and very encouraging. So would you tell on an expert panel that you at this point would not recommend Bev at all?
I would not recommend it, no.
Okay. My UK experts, Dr. Nandita, have you ever used Bev? Because I don't think you would be having that sparsity of tocilizumab there. Or Dr.
No, we haven't used bevacizumab. We haven't used, and I don't. And just let me add, Dr. Beata is also PI for the remap cap with
Sorry for that.
And no, we haven't used it. I don't think it is part of our protocol.
What we were using in the UK, and it showed as good results as tocilizumab was sarilumab. So those 2 drugs are equally.
Yeah, you use in the trial sarilumab, and that was also a minority patient.
Yeah. It's the same improvement. Basically, it's a benefit of 8.5% in mortality. So for both medications.
Can I ask you something very practical? Yeah, please finish your comment.
It's practical as well. So we used anakinra as well, which didn't show any benefit, and anakinra is completely unpractical, because you have to just give the dose in every 6 hours. So there's no benefit from anakinra. There's definitely benefit from sarilumab and tocilizumab.
Okay. So one more question I have before we move on. Or as per what is your experience about how many of these patients, if I give 100 patients tocilizumab, how many had to you had to give the second dose?
So basically, we at the beginning, once we try out the patients, the protocol was very unclear. The protocol was saying if the patient is not improving, you can give another dose. Yes. But most of the patients, they improved. So then we had a problem because after 24 hours, we kind of missed the window, and then they gone into the wrong direction again, and it was too late. So this is what I would do. In current situation, in our protocol, hospital protocol, because obviously the message which is coming from the remap cap, we use only 1 dose because it's expensive drug. So this is what we agreed in our hospital. We give 1 dose. However, I've seen patients after 2 doses, and they benefited.
Okay, Dr. Neil, in the US. In your practice, a double dose to few patients?
Yeah, most of the time it's been a single dose, and I think that patients have gotten better. Although in our hospital, if we basically in a 12 to 24-hour window, if the patient is not improving, or specifically if the patient is worsening, we will give a second dose, and we have done that, several times. But
what percentage of your patients have received the second dose? On a ballpark figure, maybe 10%.
10%, yeah, maybe even less.
Okay.
Yeah.
Dr. Akhil, realities of India, and then Dr. Ullas. Bevacizumab, in your vast experience, have you tried that because tocilizumab was not available?
Yes, sir. We have tried in a few patients, but response is not so encouraging. So we are not using it presently. We initially started with the publication, but we are not using it. Tocilizumab definitely we have used in a few patients.
Okay, Dr. Ullas, no Bev at all for you?
No, we have used, but so yesterday one of my consultants used, and they said it was working. The oxygen requirements has come down, but that is not the data that we're looking at. We need, Dr. Sahoo, we need long-term data. Not very convinced.
Agreed.
And I totally agree with it's not a substitute to tocilizumab.
No, it is never a substitute. My point of question was, if you don't get tocilizumab with the data, people just hang on to some straws.
Dr. Sahoo, there is a question mark in the chat box. What is the role of methotrexate? Low dose or high dose? So just because you don't get tocilizumab, you don't know methotrexate, right?
Okay. So the point is very clear from our experts that if we are in a storm, tocilizumab with steroids is the way to go ahead, and that's what it should be. and most of them receive one dose, and very few of them would receive a second dose. That would be around 10%. Dr. Kilnani, in your practice in India, how has been your experience with tocilizumab, the availability especially?
Tocilizumab has been effective, in the sense that you give it today and you start seeing the parameter is oxygen requirement on that, and that of course is a parameter of improvement. So we don't actually look at the question of procalcitonin, which sometimes is not available at that particular moment. And procalcitonin being a quantitative test, this was not you asked for, but I'm commenting. Procalcitonin being a quantitative test, nobody knows whether if it is 3, you go ahead and give. If it is 10, you don't give. You have to save the patient. You have to save the patient. Therefore, we give. About tocilizumab, the results have been good. Bevacizumab, we are giving because tocilizumab is just not available. You have to save the patient.
So what have you found with bevacizumab?
The numbers are too little for me to say anything on this forum.
Next slide, please. Yeah.
Dr. Sahoo,
So this
why
is
don't
the
you tell us about the your experience? I think you posted in WhatsApp group.
I have given to 6. Tocilizumab was just not available, and I was lucky. It's God's divine hand or anything which I told. 4 out of my 6 patients have gone out. 3 of them out of ICU and non-invasive ventilators. The first thing what I find was the oxygen requirement came down drastically in 2 to 4 days, into 24 to 48 hours. So this is my experience. Maybe I will lose the next.
No, my point is, Dr. Sahoo, was it given in severe or a moderate case? I mean, again,
severe. All of them were severe, where the saturation was 80 or 85 at a requirement of 10 to 12 liters. That's where desperately I had to go on with the X-ray deteriorating. That's how my patients did. So maybe the next 4 might not. I hope my good run continues.
I hope they do.
Yeah. So this is the recovery which has really generated a lot of interest. Here the CRP, the inclusion was 75. And that's where they included the C-reactive proteins, included more than 80 beyond all age. All of us know this. It's on a free publication. Next. They use steroids. That's one thing very important. And that is what it is in the next slide, please. And tocilizumab helped. All of us know that. Next. Yeah. So here I want to come in and ask Dr. Sheila with her experience. And then I will like to go to the experts in UK. There is a very clear subset analysis, which you might not take conclusions, but what they're telling is if you are on an invasive ventilator, and if there is a patient, this patient received tocilizumab, it really does not make a difference in mortality. What would be your take-home message for that?
This is absolutely correct, because it's too late. I would say it's too late. And if at all you use it, I would use it within the first 24 hours. And I want to tell you that based on the remap cap and the recovery data, earlier we were not using in between tocilizumab much, but this is evidence is evolving. And I'd like to tell you that I'm part of the Surviving Sepsis Campaign guidelines, and they are updating the recommendations on tocilizumab to start it early in severe and critical COVID in those patients who are already on steroids, and those who have elevated CRP, and definitely not in ventilated patients. If at all you use it, perhaps in the first 24 hours, but definitely no role otherwise in ventilated patients.
Dr. Makowski and Dr. Nandita, your experience, what has been your experience? Because in the remap cap, nearly every patient was on a non-invasive or an invasive ventilator. In contrast to recovery, where around 50% were not, they were on oxygen supplementation. So what is your take? Is oxygen supplementation the right time with the cytokine storm or the invasive ventilators? Because it's a very costly drug and people here pay out of the pocket. That would not be the right setting for us to give a tocilizumab.
So in my view, the protocol says give tocilizumab once the patient is in the critical area. So we used to start, and it needs to be supported. So some way. So whether it is an IV, non-invasive ventilation, or patient intubated. From my experience, as early as possible. Once the patient is at that stage that requires some assist ventilation or CPAP, or is just intubated, I think then patient can benefit from the tocilizumab later on. We haven't given actually later. But I don't think it's indicated.
Okay. So basically,
sorry,
please.
Sorry,
Please.
the
Dr.
same thing with
Nandita.
Parikh, is that we gave it we admitted patients in critical care who required non-invasive ventilation or ventilation as such. So and our protocol suggested tocilizumab only after admission to critical care as part of the REMAP-CAP trial, but within the first 48 hours only. So that's what we did.
So are you suggesting that even invasive ventilation patients do benefit?
We did give it within the first 24 to 48 hours, yes.
Okay.
We don't have any evidence in this matter.
Yeah.
So we just follow the findings from the REMAP-CAP trial.
Okay. Dr. Neil, your take on the tocilizumab final take, and then we move on.
Yeah, so I agree with the kind of opinions that were just shared. For the most part, we typically start it when the patient is moved to the ICU, deteriorating, as early as possible. Usually we try to get it on board within 24 hours, and we do give it to patients who are ventilated as well.
So the impression I'm getting is that you identify the storm early. You quickly go on to give one of this tocilizumab. Do not wait, and the later you give it, it is not going to benefit. And definitely there is data that's emerging that in an intubated patient on invasive ventilation, the benefit would be less to marginal. So probably the earlier is better. Okay, next slide, please. Yeah, this is something which all told that the corticosteroid, if you go down to the lower part of the forest plot, the corticosteroid use did benefit to the for tocilizumab. That's from the recovery data. Next. Yeah, so this is the actually the benefit, absolute benefit, if in terms of is 15% benefit when you look at the meta-analysis, and the best benefit actually has come from the recovery and the REMAP-CAP. All the rest trials, to be very fair, were very small. That's why you see the lines all across. Next. Yeah, so take home, tocilizumab is for patients with cytokine storm. That's what the take-home message was. It should be started early, 12 to 24 hours. What it is, it's mainly a clinical diagnosis. Although a lot of the experts did point out towards the C-reactive protein, that is also has been taken into account in the recovery trial. Next. Yeah. There was a chat box. Can you go back one, please? Baricitinib. This is a new kid publication there. I can go into Dr. Nandita. Your experience, have you used it?
No, we haven't used it as yet.
Okay. So Dr. Kilnani, your experience, because there is a data that if you give it remdesivir in the right patient, you might decrease the incidence of a storm and probably also the mortality.
But I have no experience with baricitinib, so I won't be able to comment on that.
Dr. Akhil and then Dr. Sheila. Akhil, any experience?
No, sir, we have not used.
Dr. Sheila.
Sorry, I was muted. So I have no experience with the use of baricitinib, and this is again based on the NEJM trial that the combination of baricitinib with
next slide
remdesivir is superior to using remdesivir alone. But the evidence for using remdesivir itself is weak. So I would say we need more.
So agree. So the point of contention is we have now a generic baricitinib. So baricitinib is the generic which I found out. I used first patient today actually. Is around 420 rupees only, Indian rupees. So it's so cheap for a 14 days course. So if I have the generic, I'm not talking about Eli Lilly is the thing, the NATCO has it. So if I use it in the patient whom I feel is eligible for remdesivir, so and I can decrease the mortality, and that's what the primary endpoint was. And they also told the same thing that in the intubated patient is not going to be beneficial. So wherever there's a benefit of remdesivir, with this data, Dr. Kilnani or Dr. Sheila, what do you feel with a 400 rupees tablet for 14 days? Would you just not think that it is good enough if the patient is not renal compromised? The point is it's 4 milligrams per day.
So if you ask me, baricitinib is not actually meant for very severe cases or for the critical illness.
It is not.
It is to be started early. That is
moderate case fit for remdesivir.
Yeah. But I wouldn't compare it with remdesivir even today, given the large experience of remdesivir that all we have. I till now will consider it as an experimental drug and not to be used for clinical.
Okay, so how I look at it, I look at it that whenever there's an indication for remdesivir, and in this trial published, there were 10 days because the collaborative group put it as 10 days, then they got the 5 days of remdesivir. So if the patient is fit for remdesivir, oxygen supplementation, that is the right patient for us. Even for a BiPAP support, that you could add baricitinib. The dose is 4 milligrams once a day for 2 weeks. For renal compromise, GFR below 60, it's 2 milligrams. So I think this is a good addition, and it doesn't pinch the pocket. The toxicities are good enough. It's a JAK2 inhibitor. Next slide, please.
Our hospital has some kind of newly released guidelines. I haven't used it personally, but most of our patients are on remdesivir. But for patients that are on remdesivir, and for whatever reason, if they cannot get steroids or they're not eligible for tocilizumab, we will consider adding baricitinib at that point. That was kind of it's a new guidance issued by our hospital for practice.
And it makes sense. It makes sense, and especially when this drug is so cheap in India. So last 5 minutes, I will just have an opinion. Neil, first you, because I think, do you have experience on this dual neutralizing antibody cocktail?
I don't have a whole lot of experience on this. From what I know about it, more useful in kind of the early outpatient setting in patients without severe disease who are going to potentially are at risk for progressing disease, who are caught early. Often the patients I know that have been on it are people who essentially have been fairly asymptomatic but are high risk. They're in the hospital for some other reason, and they were caught. They came back with a positive COVID test, and were kind of given this cocktail, and they've all done very well because we know that the monoclonals work, especially for variants that don't have the E484 mutant that is escaped, but the double cocktail does still have some good activity. So I don't have a lot of experience, but
this is actually a monoclonal antibody which is targeting the spike protein, and this is casirivimab and the imdivimab. I'm sorry, this pronunciations get little. We need to get acquainted to this little bit. But Dr. Parikh, sir, I will bring you here with your experience, and this is a good data for me because. For me, when I look into the data, the phase 1, phase 2, and the phase 3, if I collaborate all the data together, and they are put together in the high-risk patient who are mild or asymptomatic on an OPD basis, you just give a subcutaneous injection, and cancer immunosuppressive therapy for them is a high risk. The chances of getting a progression to a hospitalization is decreased by around 70%, and that's huge. So, Dr. Parikh sir, what would you recommend once it is available? Would we, as oncologists, medical oncologists, for the mild patients who are COVID positive with the fear that they do not progress, would this be a right option for offering them?
As is true for almost everything in life, this is like too good to be true sort of picture.
We have a phase 3 trial.
Yeah, and it's only once in 10 years or a decade that we get such data. So I think that I would be stupid if I don't make use of it in my patients when it becomes available. Then probably with that personal experience, then we will know whether it's really true or not.
Anyone in the panel wants to point something? Next slide, please.
The one thing I want to point out about the monoclonal antibodies is looking at the kinetics of viral load. Viral load in the patient is highest actually on the day of hospital admission. So when you look at viral load, you really have to get lucky to catch this early in a patient who's either asymptomatic or very mild.
Why I'm speaking is when we as medical oncologists, we do the routine COVID test before we plan a chemotherapy, and we do pick up those patients asymptomatic, the COVID positive. So I think this makes more sense to those patients.
Right.
So this, if you look at it, and I'd like to have Dr. Khilnani for his opinion before I finish this slide, and then I'll take his opinion. This is actually what it is, that irrespective of the dose, they had a high dose, the 8,000 milligram, the 2,400, they also had the low dose of 1,200, and even a 600 milligram dose is there. They found all the doses were equally effective. That's take home point number 1. And they found that placebo versus this dual monoclonal antibody against spike protein, they found that the viral load decreased significantly. And that's what it is all about. Next. And they found that patients who did not have antibodies, for these only the drug acted. If you have a protective antibody, the drug did not act. Next. And if you look at it across the loads of virus, irrespective of the high and low viral load, it worked across. So Dr. Khilnani, this is the data published phase 1, phase 2, and the phase 3. Are you interested? Especially for that The renal failure patient, immunocompromised, obese, high-risk patient.
I'm actually impressed with this data. Anybody would be impressed with data because it stands to reason. And lack of evidence is not evidence to contrary. I always feel in clinical medicine, especially intensive care. So this makes sense. I also would like to bring a study which came about 3 months back in JAMA, where plasma therapy given in first 3 days of the onset led to significant diminution in the severity of. So both are same. You act early with antibodies. Now this is monoclonal antibodies. Those antibodies are preformed antibody in a patient who has already developed COVID. So the logic is same, that you hit early with the preformed antibodies. So this particular study exemplifies or proves that hypothesis or the thinking that when in the first few days of the illness, if you give antibodies, you are likely to reduce the severity. Thank you.
Ullas, when it's available to your patients, because it's a subcutaneous as OPD, or you can have a short infusion if it is mild patients.
Looks interesting.
Yeah. One more thing which I wanted to, before finish, time is getting out. They also had this trial done on the contacts. Means you have a contact of COVID positive and the contacts are COVID negative. They gave a simple subcute injection, and there were 81% reduction of not getting COVID positive. So this is the data, and this is what it is. Next slide, please. Okay, so phase 3 data, prevention, asymptomatic, we have all covered this. Basically, you don't give this combination for hospitalized patient. That is something which I want to reiterate very, very clearly on this. And for Akhil, the company which you asked was NATCO, which I know has made it available in India. Second, Dr. Akhil has a question, and I would like to ask Dr. Nandita, IVIG, any experience of IVIG in COVID in UK? Do you prescribe it in any setting?
Sorry, no, we don't use IVIG for COVID as such. I haven't used it. Not during mine.
Okay, Dr. Sheila, that was Akhil had put that in the chat.
No experience with
this. No. Okay. So with this, I think I will stop here. And I think Dr. Purvish sir gave me 2 responsibilities. I could fulfill a little bit of it. Any one of the panelists could add anything more about the tocilizumab or the cytokine storm or this new data which I have put forward. They're more than happy. I'm more than welcome.
Can I just say, I had a very two elderly patients. They're 78 and 76, and they were on 100% oxygen, on the high flow oxygen and we gave them, both of them left hospital. So we started them within 24 hours, they came straight into critical care. But I'm not saying that it is, and we had started steroids as well. So, and one of them had to be given a second dose, but they both did well. I mean, we had put them in the REMAP-CAP trial. So that,
okay. So Dr. Sahoo, I have a question rather than a comment. I think Jatin Sareen has asked in the chat box that what is the maximum dose of steroids before we go for TOSI? So is there a maximum duration of steroids or the dose of steroids that we're looking at?
If I get it, I can ask Dr. Beta to answer that. But my impression is they're already on steroid. You give the tocilizumab along with that. That's my impression of. So the Dr. Beta.
So wait for any time, 4, 5 days, 7 days.
We don't think so.
We normally
Dr.
give
Beta.
steroids. We start with small dose, 6 milligrams. If patient is not improving, we double it. So we give 12 milligrams and we continue this up to 10, 14 days. And I wanted to mention something about the monoclonal antibody, because this is the drug which is tested still in a recovery trial. I don't think that they published data on that yet, but it's definitely safe to be given. They haven't seen any side effects of monoclonal antibodies, so it is safe.
It's a safe drug. It's a safe drug. That's true. The toxicity is too good to be true, actually. And only last thing before I stop, the baricitinib, you don't have data on the use of concurrent steroids. And the point is that they nearly act on the same thing. So that is why there is little bit controversy. Should I be using baricitinib with steroids? That's one controversy which need to be answered in the future. So any more questions, sir? In the
Amish,
Amish here.
Yeah.
All the people who are working in ICU, this question is to them. If patient do not respond to tocilizumab, is there a role of cytokine filtration? The way we do dialysis, is there? Because I have heard that there are 2 hospitals in Delhi who have been doing this with some good limited success.
The cytokine filter, that's what you're asking.
Yeah.
We haven't used it in this setting.
So I'd just like to say that people have tried it, but there's no data to support this practice. I mean, it may have worked for some people, but I would say that, I would not recommend.
Tocilizumab itself has decreased hemodialysis incidence. So why not take that? That's what would be the answer.
Okay. The reason of asking this question is that, COVID is such a new and such a devastating thing that, on one side, like a lot of people criticize Tarini and about bevacizumab, cytokine storm or baricitinib or other things, lack of evidence. But what do? Do we let patients go looking at them helplessly if the tocilizumab is not working? Or do we keep trying like IVIG, cytokine filter? There is a helplessness versus looking at the evidence and working only at the evidence. I feel there is a very thin line between the two.
Yeah, this last question, very interesting. Looking at mucormycosis from Dr. Neil in US, what is the incident? Because India in the last 3 days only mucormycosis is in the media, and in UK because you have had the waves little earlier than us. So are you dealing with the same problem, or is it just a matter of time?
For mucormycosis infection with, is that what you said? Sorry, I missed.
Yeah. Mucormycosis, COVID, steroids.
Yeah. There has been certainly some of it in the hospital. Okay. We have seen it. It certainly it occurs, and then we treat it, and the patients usually do okay.
Dr. Makowski, in your ICU, do you find this a troubling thing? Because what we are getting it is like it's too much, little much. What's your take on that?
So coming back to the previous question about the cytokine storm and hemofiltration. So from our experience and from our data, the mortality goes up once you put the patient on the filter. Obviously, you've got another organ to treat, but I think it's kind of treatment which is supposed to filter the cytokine storm as well. So it means that it's probably not very beneficial. I don't know. There's no more data on it. So what was the other question? Sorry.
Yeah, and the problem of mucormycosis. Have you faced it?
No.
Is it a big problem there? Okay.
No.
So Dr. Sheila and Dr. Nikilnani, last point, if I can take before Dr. Purvish takes over, why is mucormycosis then a big problem? Because the country we already had mucormycosis, and that's why it is just accentuated.
Perhaps Sir can speak, or I can say that. So I work at Tata Memorial Hospital, which is a cancer patient hospital. And I can tell you that since the onset of the pandemic, we haven't seen a single case of mucormycosis. We're using a recovery dose of steroids. We use 6 milligram dexamethasone for 10 days. We are not using high dose methylprednisolone, no pulse dose. And I see a lot of people in general hospitals outside talking. Of course, there's a lot of media hype as well. And whatever reports I saw in the literature, there are 43 reported cases and 70% of this comes from India. So definitely, and I haven't seen a proportionate, probably the oncologist will be able to comment on this rise in the aspergillus and other fungal infections. And everyone's talking about mucor. So perhaps there is a rise in the incidence of mucor. And from whatever I've heard from people, it's more in patients who had high uncontrolled diabetes, or the sugars were all haywire. These were the patients who were the ones who were more susceptible to get this, and on high dose steroids.
Correct. So I think Gujarat seems to have unusually high number of patients with mucormycosis that have been reported. And in my previous hospital, Shalby, I know of at least 12 or 13 patients who have undergone surgery for trying to get rid of the mucormycosis. In fact, the pegylated amphotericin B is just disappeared and is not available for treatment.
Sir, we are close. We are,
Okay,
yeah,
okay.
please.
Great. Thank you very much,
Thank you.
Amish, Ullas, and Sahoo. Thank you very much, all the panelists. I think this has been a really intensive discussion, and this is truly what is required for better management of our patients on a practical basis. We'll meet again in 2 days' time on Thursday at 7:30 p.m., where we will carry on from here. And the main point of discussion on the next meeting will be moderated by Dr. Ullas Batra, and we want to go in depth on how to use oxygen and what to do when the patient is requiring oxygen. So with that, I thank everybody once more. Please stay safe and join us again in 2 days' time on Thursday at 7:30 p.m.